Okay, welcome. Happy New Year. Let's get started.
All right, so I've got a few questions this session. So let's have a look, see what we're dealing with. Okay, you mentioned on one of our recent calls that you don't want to start fixed braces too early, as this will drop the face down back. But how will fixed braces drop the face down more than removable appliances? I understand the negative effects of fixed braces during the teenage growth spurt. So if you understand the negative effects of fixed braces, then um, we apply the same principles to starting treatment either in the early teenage years or pre-pubertal in the full permanent dentition. Growth is greatest and most variable according to the external environmental inputs in that early growth spurt. So if you have a favorable input, then you get a lot of gains. If you have a negative input, you get a lot of losses. As far as the difference between fixed braces versus removable appliances, ultimately what creates increased vertical is a increase in bad posture. We tend to find that braces, when we tie molars, premolars, and incisors together, you have a stimulation for eruption. So any teeth you tie together and move, the easiest movement in all circumstances is eruption. So if you tie your molars, premolars, and incisors in an active force, then the molars will erupt. Erupting molars opens the bite, so increases the vertical. Multiple teeth on the move are uncomfortable, so the bite forces reduce and the posture usually worsens. What's the difference between a removable appliance compared to fixed braces? Well, removable appliances cover the palate in our appliances, so it acts like a transpalatal arch, which locks the molars together, holds width, but also reduces the effect of molar eruption because you're anchoring on the ease and you're using the rest wires to control the eruption of the first molars. In addition, our program relies heavily on improving posture through the exercises and through awareness. So that counters increased vertical because we're correcting the postural deficiencies. Next question, assuming I start expanding a 7-year-old with upper and lower stage 1 appliances, I'm done once all the incisors are erupted and tidy, around 8 to 9 years of age. At that point, what type of retention would I recommend from end phase until permanent dentition? Parents are asking me at the beginning of treatment how we will retain. I understand go effects, but anything else? For example, from 7 years of age, active expansion, upper and lower, and the exercise of good oral posture exercises. Then from 7 to 8, retention of the upper, continuing lower expansion and exercises. Then 8 to 9, retention with incisors changing over and adding in the finishing exercises. And then now what, if anything, for retention from 9 to 12. So your phase 1 finishes when the incisors have aligned and you've got the transverse width and you've changed the posture from open mouth to closed mouth. The goal is to get that done before the D's and E's are lost. Once the D's and E's exfoliate, the goal is to stop all active appliance and passive appliances to allow the teeth to change over and the leeway space to close so that your molars can move into their correct final position. So you're finishing with changing posture through exercises. Prior to the E's being lost at around 11 or 12 years of age, you can continue to wear a lower stage 1 and you're going to make an upper passive retainer anchoring off the E's. So it's like a stage 1 appliance, but without the screw. So you're holding space once you've made the space until the primary teeth are lost. And you're retraining the child to control that space themselves with the exercise program so that when the final changeover starts to occur at around 11 and 12, you should be appliance free and posture strong. So that's the game plan. All right, so our goal is to create space, improve the permanent dentition that's existing in the mixed dentition to be better aligned, get the bite relationship to sock in well, and then train to improve posture and the swallow function so that we can use natural, self-guided correction for the permanent dentition final changeover. If we haven't mastered all the techniques, then there'll be relapse, there'll be unguided eruption, and then a phase 2 will be required in the teenage years, usually with fixed braces and a return to the exercise program. Okay, next question. I'm currently watching the 2-day intro seminar. I'm confused about the literature review. You start off reviewing all the studies that prove early orthodontic phase 1 intervention does not work. Then you review the 90% relapse rate of currently accepted fixed ortho treatment. But at the end, you review literature showing that treatment does improve outcomes and stability. And you summarize the difference between these two sets of early intervention studies. Understand that in postural orthodontics, you're treating the etiology malocclusion, but these studies are not including postural therapy, right? So as far as I'm aware, almost no treatment today focuses on improving posture. So none of the studies are posturally driven. Lots of them are functionally driven. Lots of them use mechanics, but I'm aware of almost none that focus on improving posture. why is there such conflict between the literature? Why am I showing that early intervention doesn't work, and then I'm showing early intervention does work, and I'm showing that fixed braces works, but fixed braces doesn't work in the long term? I want to highlight that orthodontic treatment is essentially a scientific process that isn't very strongly evidence-based. We don't have any real definitive answers for anything that we do in ortho. Orthos in the scientific realm recommend evidence-based treatment, as we would do in any form of dentistry. And so we cite studies that are high-level randomized controlled trials. The reality is almost nothing that we do in orthodontics has high-level randomized controlled trials to verify the validity of that treatment. We don't even have randomized controlled trials to guide us into arch wire selection. Right? We have randomized controlled trials for a lot of what we do, but the outcomes are so variable that there's no evidence for any form of treatment other than in class 1 malocclusion. There's actually no evidence to show valid, guided, recommended treatments for any form of class 2 malocclusion treatment in orthodontics. So I'm highlighting to you that the claim that you should only ever do evidence-based treatment in orthodontics is possibly a little bit of a fallacy, because the majority of the treatment of class 2 malocclusions is non-evidence-based, as shown by the evidence in literature reviews. So if we're treating class 2 malocclusions using non-evidence-based techniques, how can we say we must only ever treat evidence-based techniques? All right, so I'm trying to show that when someone claims there's no evidence to do early intervention, we have to agree with them. Yes, there's no evidence that is at a high level to support the treatment of early or interceptive mixed dentition and primary dentition malocclusion. True statement, factual statement. Where we have to be mindful of perspective is there's actually no evidence to support any form of treatment in class 2 malocclusion. Yet we happily treat class 2 malocclusion using orthodontic techniques, which are what we call standard of care. What is the difference between standard of care and evidence-based treatment? Sometimes they are aligned together. Your standard of care treatment is evidence-based. Other times, as we have shown in the management of class 2 malocclusions using orthodontic techniques, is because there's no evidence-based treatment, standard of care is majority rules. If every orthodontist agrees that they want to treat class 2 malocclusion with fixed braces and TADs and class 2 mechanics, then that becomes standard of care, even though there is no evidence basis to recommend treating in that method. So I want you to understand that orthodontic treatment, the vast majority of skeletally based treatment is actually non-evidence based, but rather is standard of care based. Now, does it mean that any form of non-evidence-based treatment can therefore be used, because obviously a lot of treatment in ortho has been agreed collectively to be used even though there is no evidence basis for it. And the answer is, of course not, right? It has to consistently work. So your goal is to seek out evidence-based practice, but when there is insufficient evidence base, your goal is to make sure whatever you do works consistently well. If it works consistently well, even if it isn't evidence-based, then you can justify it. If it's not evidence-based, and if it doesn't work consistently well, don't do it, because you have no evidence to support it, and you're doing something that is causing more harm than good. This is how we interpret experience, evidence-based, and patient wish, which is the foundation of informed consent. This is how we interpret and understand and provide informed consent. Knowing what works, what doesn't work, what is evidence-based, what isn't evidence-based, what is standard of care, what is unacceptable care. What is patient wish? What is clinician experience? Anything that we do in dentistry must follow the medical model. And this is the process of expressing the medical model in a professional manner. Next question. Do you start doing GoFX and froggy mouth once you finish with upper active expansion, even if you haven't finished expanding the lower arch yet? Well, if we haven't finished active arch development, we're not ready to finish our treatment. GoFX and froggy mouth require a stable bite relationship to be able to be utilized effectively. If you don't have a stable bite when there's no appliances in the mouth, you're not ready to finish, so you don't start the finishing exercises or the froggy mouth, which is again a finishing exercise process. Next question. I am new to postural orthodontics and have about 8 cases. I have 2 cases currently with upper appliances with cross-bite flanges. One is consistently having problems with the appliance not fitting and needing to come in on an emergency basis for me to adjust the class. Other than the common problems you see them biting them into place, do you find the cases with the cross-bite flanges have more issues with the appliances not fitting after adjustment? It seems he's doing fine for a week, then after 1 week it suddenly doesn't fit after he takes it out for brushing his teeth. So cross-bite flanges are much more difficult to stabilize compared to regular stage 1 appliances, because it is an appliance that will interfere with the bite relationship. All right, it's changing the child's bite habits, and so there are torquing forces against the bite flange. That said, it's never a problem unless the child takes the plate out to eat. All issues are almost universally related to not eating with the plate in. A crossbite flange takes much more getting used to when eating. So usually, unless the protocol is strictly adhered to, the children almost always take their plate out to eat. And that is the reason why the plate stops fitting. If we take the plate out to eat, defeats the purpose of the crossbite flange. And if we add in the burden of expanding before we've learned to live with the plate full time, then you're guaranteed that after a few days, the plate will stop fitting. So the process must always be the same. We don't expand the plate if we're not wearing the plate full time, if we haven't figured out how to eat with the plate in, and if there's any loss of retention and if there's any discomfort. We only ever turn the plate screw when we're eating with it, we're wearing it full time, it's not sore, and it's nice and tight in the mouth. When one of those things isn't adhered to, but we continue to expand the plate, that's usually when you have problems. And crossbite flange plates, the kids almost always take it out unless you enforce the rule. No plate, no food. How long does it take for a child to get used to it? Depends on how strict you are. If you follow the no plate, no food rule, within a few days they will eat with it, because if they don't, they'll starve to death. If you play the game of, oh, just take it out for this meal, then it sets the precedent where they take it out for every meal. But the parents forget the rule of no turning if they're not eating with the plate in, and they start turning, and then everything falls apart. Next question. You mentioned in your 2-day lecture that class 2 mechanics functional appliances don't work that well. Can you please explain exactly what you mean by functional appliances? How are they different from the bi-block stage 3 appliance, which postures the mandible forward? So we know the literature has shown that functional appliances don't change the skeletal pattern of growth. Right? So that's where the literature comes in to show that early intervention is not particularly effective. We know through literature of randomized controlled trials that no skeletal changes appear to occur, and any that do occur relapse back by the time the growth is completed at the maturity in early adulthood. Functional appliances are designed specifically by holding the jaw forward, by forcing the mandible to lock into the maxilla appliance, and predominantly it retracts the maxilla down and back. An orthotropic bi-block appliance, such as a stage 3 appliance, has a specific component that doesn't allow the child to hang their mandible off the upper appliance, because it is uncomfortable to do so. It's painful to do so. Instead, because of the discomfort induced when you hang your mouth open against the appliance, it forces the child to actively close upwards into intercuspization with the upper appliance. And so there's a vector of force that drives the mandible up and forward rather than pulls the maxilla down and back. So that's the fundamental difference. Okay, so next question. Bi-block appliance has to be worn 24 hours a day. Yes, it's a full-time appliance. It's worn other than taking out to brush your teeth and clean the plate and turn the screw. So it's effectively 23.5 hours a day, yes. The appliance is not wearing when you are washing your teeth and turning the screw, yes. If you are wearing the bi-block when you're eating, you have to wash your teeth after every meal. So ideally, that would be good, but the reality is that's never going to happen. So what we recommend is after each meal, instead of taking the bile block out, the child goes to the bathroom and rinses their teeth with water to clear the debris. If they don't have access to the bathroom, then they take a swish of water and rinse and swallow after each meal so that they clear the bulk of the food debris. If they have access to the bathroom, then yeah, after each meal, they take the plate out, wash the plate, wash their teeth. If they have the correct training, after every meal, they'll go to the bathroom, they'll take the plate out, wash the plate, wash their mouth, put the plate back in. It's literally a 30-second job. That way, you have the best of both worlds of wearing the plate full time, eating with the plate in, but also keeping decent hygiene. So that should be part of the training routine. Teach the parents to teach their child after each meal, pop to the bathroom, take the plate out, wash the plate, wash their mouth, put the plate back in. Next question. Is it okay to wear the bar block 24/7 for posture? Because posture is your teeth together, lips together, tongue to the palate for 4 to 8 hours a day at rest. Is it okay for the tongue posture in the bar block appliance 24 hours a day? So theoretically, it's a bad thing to have anything in the mouth that will stop the tongue from resting on the palate. With any bulky appliance, such as the bar block appliances, you can't physically rest your tongue directly against the palate because there's a chunk of plastic in the way, right? So, no, it's not ideal to have anything in the mouth. The reality is we have to pick our battles. We want a situation where the lips are together, the teeth are together, the tongue is on the palate and the floor of the mouth, in a nice soft resting posture for up to about 4 to 8 hours a day, and ideally at night time. The reason why the kids need your help is because they don't do that. In fact, most of them have their mouth open all day long, all night long. To a degree where there's so much distortion that you can't actually get a decent resting posture. So we create artificial appliances, fire blocks, that will change the shape and the form of the arches, guide the teeth, and create an improvement in the bulk of the posture, resting position. Will it interfere with the tongue posture while we have appliances in? Absolutely. Will it interfere with the lip and the teeth posture? Not so much. Is it a bad thing to upset the tongue posture? Absolutely. Do we use the trade-off of short-term loss of tongue posture to improve the general orthopedic orthodontic form and then encourage an improvement in the resting posture with the said appliance? Absolutely. How long is that compromise acceptable? Up to many years, it can be acceptable. Do we want to get out of the compromise as quick as possible? Absolutely. How do we do that? Well, once we correct the teeth and lip posture and have adjusted the jaw relationship and guided the growth to get us a decent bite relationship and a jaw skeletal balance, then we spend time without the appliances and we start to train the tongue resting posture so that eventually the tongue takes over the role of the bi-block appliance. If we freak out about the appliance interfering with tongue posture, we have to remember These are children who spent 7, 8, 9 years with their mouth wide open. What does it matter if they spend a couple more years where their tongue isn't in the correct posture? If ultimately we can get them before puberty to have really strong posture. So that's the juggle, isn't it? That's the balance between making things worse before making things better, which is always the trade-off. Next question. Is it okay? No, hang on. How about food order? Liquid, semi-solids, and solids. It means that you have to give a knife and fork for eating solid foods at 6-month-old child. I didn't understand how and when the child have to start eating solid food. So in the modern world today, we tend to follow a pattern where we feed our young children, infants, liquid. Then we transition them to semi-solids, which is like mashed potato, baby jar food. Then we introduce solids. Right? So that progression seems to make sense. It seems to follow a logical process of consistency with having no teeth to having some teeth to having many teeth. Right? Because of that particular biological growth timeline and time order, from a logical perspective, it makes sense to go liquids, semi-solids, solid. What the research, however, has shown is that is not how we're meant to develop. We're meant to be able to go from liquids to solids to semi-solids. That's just what has been shown in the swallow research, mastication and eating research. The reality is we go from the breast to hand feeding. The child picks up with their hands food and they play with it. When they figure out how to chew, then it moves to the ability to swallow, and the ability to swallow in an adult physiologic swallow occurs only after the D's and the E's erupt into place. And at that point, the child is able to chew and break down foods into semi-solids and then correctly swallow with their teeth together using a peristaltic action of the tongue. When we go from liquids to semi-solid, we are effectively forcing children, infants, who are not ready to swallow semi-solids and solids. We disrupt their physiologic action in swallow, and they end up not suckling, which is liquid, not swallowing, which is semi-solids, but doing what we call a suck swallow. It is this disruption of the natural timeline course of progression that creates all the issues. Solid foods are eaten when you have molars, when the D's and the E's erupt into place. Before that, we should be on liquids. Semi-solids are naturally developed when you take solids and you chew them up into mush. Taking a 6-month-old and force feeding them off a spoon semi-solid foods like mashed potato or Heinz baby tin food or jar food, creates a disruption to the natural order of progression. They will try, because they don't have molars at 6 months, years of age, to suckle the semi-solids, and they end up forming a suck swallow instead of a suckle and a swallow. When they have cut through their front teeth, you give them foods that they can hold in their own hands, and they gnaw on that food with the incisors that they have. And it's just plain. There's no nutritional benefit. It's just teething and mouthing and getting used to loading the muscles and the jaws. Next question. How do we get the TS retractors in Europe? If you can't order from America, then you can still get finger retractors through orthodontic supply houses or eBay. Right? TS retractor is just one specific brand, but there's lots of manufacturers who make the little finger J hook retractors. They're just called finger retractors. They're available off eBay. They're available off your dental supply houses. Last question. Where do we find this pillow on the chair? That's a car seat neck pillow. So look at your auto supply houses, eBay, Amazon. It's just a neck pillow for a car seat headrest. So
Okay.
car seat, headrest, neck pillow. All right.
Any other questions from attendees? Dr. White, Lou, Ling? Otherwise, that's the
I'm
wrap.
gonna my lunch break. Fantastic, guys. Thanks so much.
Okay, thanks, Simon. Bye.
Bye-bye.